Okay, hello everyone, and welcome to this webinar. And today we are going to talk about implant maintenance and new periodontal classification. Um, I have received a lot of inquiries and questions from hygienists, from our referring dentists, and they were interested in discussing these topics. So we put together a small presentation for you guys today. So let's begin. I'm going to point out that this is the new classification which came out in 2017. A group of experts from all over the world got together and created this new framework. As you can see on my slide, there are two main categories in under this: periodontal diseases and conditions. And for the first time, it's peri-implant diseases and conditions is included in this classification. Uh, the key points of this new classification is for the first time uh, we are defining what is gingival and periodontal health. Um, the aggressive periodontitis, which most of us were familiar with in the old 99 classification, has been merged together with periodontitis. Research has suggested that aggressive periodontitis as a distinct disease entity there was not enough evidence, so they merged it into or under the periodontitis category. There's a staging and grading system for the periodontitis um, that we need to do for every patient. Peri-implant health and diseases, as I said, is new under this classification. There's a new classification for gingival recession. Biologic width, the term has been replaced by supracrustal attached tissues. The term excessive occlusal forces from the past old classification has been replaced by traumatic occlusal forces. So let's dive into, or let me point out where you can find resources on this new classification. If you go to perio.org/2017 WWDC, which means World Workshop on Disease Classification, you can find a bunch of resources, including some handouts which are really which could be really useful for you chairside for everyday day-to-day practice. And I'm going to go over these handouts in detail later on in the presentation. You can also look at the review papers that these experts use to come up with this framework. So a whole bunch of resources you can find under that or on that website. Again, this is the same thing. You can download these handouts from that website too. And I would also recommend the FAQs on the new classification that would give you a clear idea why this new classification system was designed, and other frequently asked questions about staging and grading and other things. I do recommend that as a good read. It's just a 3-page read, which should clarify a lot of your doubts. Okay, so let's dive into the peri-implant diseases and conditions. So my first part of the presentation, I want to discuss implant maintenance. In the second part of the presentation, we would go over the new staging and grading of a periodontitis patient. So let's start with the peri-implant diseases and conditions. It's the four main subcategories are peri-implant health, peri-implant mucositis, peri-implantitis, and peri-implant soft and hard tissue deficiencies. So what is peri-implant health? Well, whenever a patient comes to you who has single, multiple, or full arch implants, as a hygienist, you should do a visual inspection of the tissues around the implant for any signs of inflammation, swelling, etc. You should probe around the implants. That's my recommendation, and I do get a lot of questions. Should we probe around the implants with a metal probe or a plastic probe? Well, it doesn't really matter with whether you use a metal probe or a plastic probe. And probing, I would recommend probing around every implant at every visit, because that would give you a baseline, and you can compare your probings, um, and see if there is any disease process going on around that implant. And we'll go over that in detail later on in the slides. You should, of course, look for initial signs of inflammation, that is bleeding on probing, and record it on the perio charting. Um, Absence of bone loss definitely is a sign of health. And later on you'll see if there is bone loss, then the new framework classifies it as peri-implantitis. Can peri-implant health exist in implants which have past bone loss, or where implant threads are visible or the abutments are visible? Yes, from this example you can see on these slides, these are our patients who have been maintaining these implants, who had probably some surgical procedure done, or maybe lost some bone around the implants, and now are maintaining well. So what is peri-implant mucositis? There are a lot of similarities with gingivitis and peri-implant mucositis. Um, Again, you would find on visual inspection some signs of peri-implant tissue inflammation. You should note the color, appearance and consistency of the tissue in your chart notes when you see any signs of inflammation. Presence of bleeding on probing is another sign of inflammation, of course. Again, as I was saying, that the most important thing to do is to compare your probing depths from baseline. So it's really essential that you do probing every time, so you can have a longitudinal set of data and can track disease process around an implant. Later on you'll see probing depths around implants about 6 millimeter or less, which is higher than a natural tooth, because the arrangement of the collagen fibers around the implant is different than a natural tooth. Of course, the implant doesn't have a periodontal ligament, so we do expect deeper probing depths around implants. 6 millimeters seems to be the cutoff in this framework that the experts have provided us. But if you don't keep track of the probing depths, and you don't have a baseline measurement, then you do not know whether this is a stable or an unstable condition. Again, difference between a peri-implant mucositis and implantitis is absence of bone loss. Again, we do expect initial remodeling, which is about 2 millimeters or less. When the implant heals, up to an year is considered normal, or normal. So anything beyond that is considered to be peri-implantitis. Again, baseline measurements and baseline radiographs are really important. Peri-implant mucositis, again, as I said, is similar to gingivitis around teeth. One of the important things is reversible, and that's why I say probe every time around implants, because if you catch it early, you can treat it, and doesn't lead to peri-implantitis. If left untreated, it can lead to. So what is peri-implantitis? With all the signs of peri-implant mucositis, bleeding on probing, and crestal bone loss beyond the initial remodeling that we expect, so about 3 millimeters or more, is considered peri-implantitis. Peri-implantitis diagnosis, or the disease process itself, has been found in research to progress in a rapid fashion and a non-linear fashion. Peri-implant mucositis is assumed to precede peri-implantitis always, like gingivitis and periodontitis. That's why it's very important to catch peri-implant mucositis early. Peri-implantitis is associated with poor plaque control and patients with a history of severe periodontitis. This is talking about more risk factors. If you have a patient who lost or who has severe periodontitis, then he's more likely to have peri-implantitis associated with the implants. Um, the onset of peri-implantitis may occur early following implant placement. What the statement is saying is even before a final crown placement is done on an implant, you can have more than initial remodeling, expected initial remodeling around the implant, and that is considered peri-implantitis too. I'm not going to spend a lot of time on the fourth subheading, which involves deficiencies of hard and soft tissue around peri-implant. Today we want to discuss more about management of peri-implant mucositis and peri-implantitis. Again, um, going to the examination that concerns you. If a patient comes to you for a hygiene appointment, what are the steps that you should do? I would recommend taking a plaque score, probing, of course, around the implant, visual inspection and palpation. Sometimes I have seen that if you just use your tip of a finger and roll apical to coronal, you can sometimes see exudate or suppuration coming from the pocket. And that's a good sign that something is going on around the implant, because most of the times you can't really probe, or your probe gets stuck within the first few threads, so you can't get to the depth of the pocket. So this palpation is a good way of inspection of the implant. I do recommend radiographs at least once a year. Again, baseline measurements is what is important. So the dentist who restored the implant should have taken a radiograph at the time of restoration. And since you're seeing the patient for the 3-monthly or 6-monthly hygiene appointments, you should update those radiographs at least once a year, so we can compare the bone levels around that implant. You should also do a mobility check, because most of the times most common complications are related to the prosthetics. The abutment screw is loose, or the cement, if it's a cemented crown, cement might have washed out, or other things. So mobility check is very important. Again, as hygienists, you do floss around every teeth and show the patient how to floss. So using the floss to check the contacts is also important. If the contacts are too tight and the patient can't floss around the implant crown, then that's where you want to bring that to the attention of the dentist and have them teach the patient how to get around or use other aids to clean around the implant. I do recommend an occlusal check once a year, and keratinized tissue around an implant, which is gaining a lot of attention in periodontist circles, because we do, as with teeth, we do want a good resistive tissue around the implant. Again, the last point might be a little bit difficult for hygienists out there to figure out if it's a cemented crown or a screw retained crown. But just keeping that in mind is also important, because there can be some excess cement which is causing initial irritation of the tissue, and during your scaling, if you can get out cement, that's just one way to get to or narrow down factors what are influencing the tissue around the implant. Okay, so I did say that probe around the implant, but some examples of day-to-day practice. Sometimes it's really hard to probe around a big prosthesis or a poorly designed crown or other factors, access to that pocket can be possible. So, but try your best to angle a probe in a way that you can get a good reading, and that's when I hear that plastic probes can be useful because they can bend to a certain degree. Okay, I do recommend a recall to the restoring dentist after the implant restoration has been placed. It can be 6 months, a year. Every restoring dentist can decide what their practice protocol is, but again, the emphasis is on baseline measurements, baseline charting, and radiographs, so that you have something to compare everything to. And again, if you do the recall appointment at the year mark, then you should do a mobility check and occlusal check and contact check at that appointment. And this is just an example to emphasize why we want baseline radiographs. This patient came to me with an issue on the distal of this implant, and within 3 months we took another radiograph, and you can see that that bone loss has already progressed. So that reaffirms the point that periimplantitis can spread rapidly, and successive radiographs or radiographs comparing two baseline measurements are really important. Okay, so as hygienists and periodontists, what we want to know is how do I maintain these implants once they are restored. If it's a healthy implant, no probing depths more than 6 millimeters, no bleeding on probing. All we want to do is to disrupt the biofilm. That's our goal. You can use a plastic probe or plastic curette, Cavitron with soft inserts. Those tools would do perfectly fine. You don't need to scrape a lot if the implant is healthy and the tissues are tight. You just want to disrupt the biofilm. Another point is emphasis on home care, and you can probably teach the patient to floss with like a shoe shine around the crown of the teeth all 360 degrees, or teach them how to use a soft pick, or whatever your philosophy would be. But I would say give them the tools and the instructions of how to maintain those implants. If you see a patient with peri-implant mucositis, how do you manage that? First, I would say find out why this is happening. Is the crown cemented, or the crown is loose, or the patient was never told how to clean that implant or crown? They were never told to floss around it, use a soft pick, or the home care is lacking in general, something going on with their systemic disease. So try to find out what's going on. In terms of scaling around the implant with peri-implant mucositis, I would say you use a plastic curette. If no threads of the implants are exposed, you can use a plastic curette on an abutment, because we don't want to scratch the abutment. Or you can use Cavitron inserts. If the implant threads are visible in the mouth, then you can use titanium curettes. You can also use an air polisher, and I'm going to show you what we use in our practice. This is our air polisher that we use. So those are the different options that you can use to manage a peri-implant mucositis case. Again, keep in mind that this is a reversible process, like gingivitis, similar to gingivitis, so you want to catch it early and treat it early. If you don't feel comfortable treating in your own practice, you don't have the right tools, then you can refer out, of course, to a periodontist who probably would have some tools to manage this. One another point on this slide is shortening the maintenance interval. If you feel that the home care is lacking, but yet the disease has not progressed to bone loss around the implant, then you can shorten the interval of maintenance every 2 months. If it's a big prosthesis or you feel it's the patient's dexterity is going down, probably every month, every practice, you can decide what works between you and the patient. But that's a good strategy to shorten the maintenance interval. If you see it's periimplantitis, then I would say it's better managed by a surgical approach or an aggressive approach, not essentially surgical approach. But I would say refer out if you see bone loss or progressive bone loss. Periimplantitis management, as I said, there are two main modalities of therapy of management of periimplantitis: non-surgical and surgical therapy. There is no consensus in the literature and clinicians, so there are a lot of options out there, but I am going to point out what I have tried and what works in my practice. Non-surgical therapy, we need to figure out why is this happening. What are the contributing factors? Is the patient a smoker? Is diabetes of the patient, if diabetes is out of control, or local factors like extra cement or lacking home care, or the contours of the crown are so bulbous that the patient can't get to the base of the pocket to clean. So figure out what's going on. Again, tools I use is titanium curettes to manage periimplantitis, because there's bone loss and implant threads are exposed sometimes, or can be accessed through the pocket. Now, for the past year or so, we've been using the air polisher, and this is our air polisher from EMS U3D, and does have a handpiece that goes onto it, but ours is in the sterilization unit. And these are the nozzles that give you access to the pocket, and this is specifically for subgingival air polishing. You can use it around natural teeth, you can use it around implants. And there are two different powders that the company came out with. One is glycine powder, and they now have a newer powder which is called an erythritol. Erythritol is much smaller particle size, so much more effective to use. But you can use either powder, and I'm going to show you a video of how to use it, or how we use it in our practice. This is just an example of a case that we managed, or we are still managing non-surgically. The lower implants were already taken out before she came to me. She came to me for the upper implants, and as you can see, the contours of the crown are very bulbous. So accessing number 4 or 5 implant is almost impossible for that patient to clean. So that's why you can see in the radiograph some bone loss around it. Number 14 implant, the crown is kind of a box shaped and sitting on the tissue and has a lot of bone loss. It's almost impossible for the patient to get in there. So we tried to reshape the crowns, and when the crowns were off, we went in with the air polisher and cleaned as much as we could, and expected the gums to recede and a few threads to be exposed, but that's okay, because that makes it easy for the patient to get in there and clean, given we adjust or modify the contours of the crown. So that's the air polisher that I was demonstrating earlier. It's through EMS, and they do make a supragingival and a subgingival unit, which you can see on the left hand side, but this is the airflow handy on the right hand side that we have in our office. And I do have a video that I'm using the air polisher on a patient, So if a hygienist, such as you want to use the air polisher, it's really important that you have someone use a high suction or high velocity suction close to the tip, because this is at high pressure, the powder is coming out, and it gets everywhere. So you want to make sure you have high section or somebody helping you with the high section. The other alternative, what my hygienist uses in our office is this is a suction apparatus from Ivoclar. If I'm not wrong, it's called the Leaf, or you can use an Isolite, any device that can help you suction, provide suction if your office cannot spare a assistant while you're doing this procedure. I do have another video. In the previous video you saw, I was using the air polisher on the lingual aspect of that implant crown. The nozzles are designed in a way that the powder comes out from the tip as well as the sides of the tip, so you can use it on the straight lingual and buccal, and also go in through the interdental area and use it on the mesial and distal, and that way you can clean all 360 degrees around the implant. So this next video demonstrates how I clean it on the mesial aspect of that implant. Again, the high velocity suction close to the spray. Okay, so peri-implantitis management, the next modality is surgical therapy. And again, as I mentioned earlier, there's no consensus in what type of surgical therapy, and the decision is always a case-by-case decision. I have three options that I commonly use. One is an apically positioning the flap or the tissue with some bone resection. It's similar to an osseous surgery, flap surgery that we do around natural teeth. And the second option is bone grafting around implants, which again, a case-by-case basis. It sometimes works, it sometimes doesn't work, because the main aspect of bone grafting is to decontaminate the surface of the implant, which is very difficult sometimes to completely get rid of the bacteria hiding into the rough surfaces and the threads around the implant. That's the main issue why the bone grafting sometimes doesn't work. Implant removal and grafting the site, that's most commonly that we do, unfortunately, because it's always easier to take the implant out, graft the site, and try another implant or any other prosthetic option like a bridge, or because sometimes patients don't feel comfortable maintaining those implants, or throwing more money at a failing implant. But in some situations we can use the other two options. Again, if I'm doing any surgical therapy, I do incorporate the air polisher to decontaminate the surface of the implant, or a titanium brush on a slow speed that I use to clean the implant surface. Some clinicians use tetracycline slurry, some use betadine, other things to decontaminate the implant, but again, there's no consensus among periodontists and other clinicians on what is the best way to decontaminate or treat a failing implant. I put this as an example. This is the only case that I can remember that has worked in my hands of bone grafting around implants. Again, I did not re-enter to see whether there was actual bone regrowth or bone growth around the implant surface, but the tissue looks healthy. The patient was able to access these areas well and keep it clean, and that's what matters the most. This is an example of the apically positioned flap, and I do employ this option in few cases. For example, this lady had a lower fixed prosthesis on 5 implants, out of which 3 were failing, and you can see in the picture on the extreme left that the implants have a circumferential defect around them. And if she were to lose these 3 implants, the whole prosthesis would fail, and she would absolutely not go back to didn't want to go back to a removable prosthesis. So we tried to open these threads to the oral environment and create a gap between her prosthesis and the gum tissue, so she can use some cleaning aids and clean this implant surface better. So that concludes our first part of implant maintenance. If you have any questions, please feel free to call our office or email me or email our office, and I'll try to answer them as best as I can. Now I want to discuss and move on to the new classification of periodontal disease, and that's what we as hygienists and periodontists use daily for almost every patient. So you can see the main category of periodontal diseases and conditions is further subdivided into periodontal health, gingival diseases and conditions, periodontitis, and other conditions affecting the periodontium. There has not been much changes other than the definition of periodontal health and gingival health under the first category or subcategory. The third subcategory also, there has not been much changes other than a new classification for the gingival recession under mucogingival deformities and conditions. Traumatic occlusal forces replace the older term of excessive occlusal forces. So main area of change is the middle portion, periodontitis. So let's look at that. So there are 3 basic subheadings under the periodontitis. Excuse me. Forms of periodontitis: necrotizing periodontal diseases, which is unchanged from the old classification. Periodontitis as a manifestation of systemic diseases is almost similar to the old classification. There was an aggressive disease under this category which has been merged with the periodontitis category in the new classification. So let's look at, according to this new framework, who is a periodontal patient. A periodontal patient is considered who has an interdental bone loss or clinical attachment loss at more than 2 non-adjacent teeth, and buccal or oral clinical attachment loss of more than 3 millimeters at more than 2 teeth. What does that mean? Some situations, for example, third molars, because of malposition third molars on the distal of second molars, there is bone loss. That is not considered as a classic periodontal lesion. Endodontic lesions draining through the marginal periodontium are not considered true periodontal lesions. Dental caries around the cervical area of a tooth causing probing depths is not, or clinical attachment loss is not considered true periodontal patient. Root fractures and other examples listed on the slide can give you a good idea of who exactly you can classify as a periodontal disease patient. Okay, so as I pointed out in the resource section earlier in the slides, that you can download some handouts to keep next to your chair or in your operatory that you can refer quickly to. And one of those handouts is the 3 steps, or how to go about staging and grading a patient. But my system is a little bit different than what the academy explains on this. So I'm going to show you my system, and hopefully that makes it easier for you to follow, or you can follow what the academy recommends. And so this handout, you can download it from the website. The other handout, as you can see on the slide, is staging. What exactly comprises of staging? And the next slide would be about the grading, but I downloaded it and I use it every day, almost on every patient, to get me more familiar with this classification system. So as you can see on the slide, staging, some of the highlight points that I'm going to point out to make it easier for you guys to understand the staging and grading system. So staging a patient, the worst tooth in the mouth with bone loss determines the overall stage of the patient. In the old classification, you could have classified a patient as localized severe and generalized moderate chronic periodontitis. That no longer can be done, so each patient gets one stage and one grade. And the worst tooth, or the worst or the severe tooth, determines the initial stage of the patient. And that talks about the susceptibility of the patient overall, and that's why they did that. As you can see under staging, there are three major categories: severity, complexity, extent, and distribution. We are very familiar with severity and extent and distribution from the older classification. Severity: mild, moderate, severe, and very severe, which are stages 1 through 4, and I'm going to go in more detail about that. The new addition is the complexity of the disease, and that helps or guides the clinician in how complex this case would be to manage. That's all it's about. And depending on the complexity, you can upgrade a patient from a stage 3 to a 4 if you consider the factors listed on these stages, and we are going to talk more about that. Extent and distribution, localized and generalized. In the older classification, they used sites. Now we are using teeth. So if there are 30% or more teeth involved with clinical attachment loss, that becomes a generalized case. If it's less than 30% of involved teeth, then it's localized case. And there's a new category in this new framework, which is a molar incisor pattern. And in the older classification, that was a common presentation of aggressive or juvenile periodontitis lesions. But now we can classify molar incisor pattern with staging and grading too under this classification. Excuse me. So the easiest way to stage any patient is, as I said, the worst tooth determines the stage of the patient. So the easiest way is to pick out the worst tooth on the radiographs. If you look at this handout, stage 1 and 2, the bone loss is about the coronal third of the tooth. That classifies it, the patient as a stage 1 or 2. If the bone loss is about the middle third of the tooth, the patient is classified as a stage 3. If the bone loss is up to the apical third of the tooth, the stage is stage 4 for that patient. So what I would want you to do is pick out the worst tooth on the radiograph, divide the root into thirds, and there you have it. You'll have your stage of the patient just by looking at the radiographs. And we're going to go certain steps that would make it even easier for you to stage and grade a patient. Now let's talk about grading of the patient. The grading is divided, or the grading gives you an idea of the progression of the disease, how fast or slow this disease has been progressing. And there can be some grade modifiers. For example, research has validated only smoking and diabetes up to now. So in this new classification, they consider only smoking and diabetes as grade modifiers. But this framework or this whole classification system has been designed to be robust and dynamic, so that if later on research points out to other systemic conditions that can increase the susceptibility or progression of the disease, then we can add it to this classification system. But at present, smoking and grading are the only diabetes are the only two grade modifiers, and we're going to talk more about that too. Excuse me. So the primary criteria to assign a grade to a patient is it can be you should always use direct evidence or indirect, or the other way is the indirect evidence. So what do you mean by direct evidence? If you have radiographs from or within 5 years, and you see more than 2 millimeters of bone loss on those radiographs, then you can clearly say that the rate of progression is a rapid rate, which means grade C. On the other extreme, if you see no bone loss over the last 5 years, you can safely say it's a grade A, or a slow rate of progression of the disease. The indirect evidence, what does it mean is sometimes you do not have previous radiographs sent by the referring dentist, or if the patient moved, or whatever the situation, if they are not available, then you simply divide the age of the patient and the percentage of bone loss on that worst tooth that you picked out, divide the percentage of bone loss with the age, and you'll get the rate of progression. If the rate of progression, or using the indirect evidence, if for example in this case the bone loss is clearly up to the apex of the tooth, so this about 90%, so the percentage of bone loss is more than the age of the patient, that makes it a grade C. If the percentage of bone loss is half or less than the age of the patient, then it makes it grade A, the other extreme of the spectrum. If it's between half to 1 ratio, then that makes it moderate progression, or grade B. And we're going to look at some examples, and I'm going to make it easier for you to understand more. Okay, so what are the key points of this framework of staging and grading? As I said earlier, there could be only one stage and one grade for each patient. The worst tooth determines the stage of the patient, and that's how you determine the grade also of that patient. If you look in your handout, under the staging and complexity factors, you can see a lot of things listed which can upgrade your stage depending on what these conditions, if they are present. For example, missing teeth. If the missing teeth, the difference between stage 3 and stage 4, they're both severe. But if you're missing 4 or more teeth, then it makes it more complex. The case is more complex to manage, so it is automatically a stage 4. If you have migrating or flaring teeth, if you have ridge defects, if you have occlusal trauma on top of periodontal disease, severe ridge defects, that all upgrades or makes it complex to manage that case. That's all this means, and the complexity means. So keep those things in mind. If you count the missing teeth, look at other things also that can point you in a direction that this case is going to be harder to manage than you thought. So here's my formula, or a way of making all this easy. If you follow these 6 steps, I am sure you can stage and grade a patient within 5 minutes. For the first 4 steps listed here, all you need is full mouth radiographs. And without even looking at your charting, you can assign a stage and grade to this patient. Okay, so what are these 6 steps? The very first question is, or the step is this a periodontitis case? Remember, I defined, or we defined, what is this framework defines who is a periodontal patient. A patient who has bone loss on the distal of the second molar because of third molars is not a periodontal patient. So you need to first define, is this a periodontal patient? The next step is, what stage is it? And I'm going to walk you through all that. Is it generalized? What is the extent of this disease? Generalized, localized, or molar incisor relationship? What is the grade of this patient? All these 4 steps can be done just by looking at the radiographs. In some situations where the radiographs are not clear, for example, you have big exostosis and you can't visualize defects, vertical defects, you might have to look at probing depths. So there are a few caveats to it, but I think most of your patients, you can look at the radiographs and come to a stage and grade. The next 2 steps are risk factors. As defined by the framework, we have just 2 risk factors to look for: smoking and uncontrolled diabetes. If the patient smokes 10 cigarettes or more, he is automatically a stage 4. If he smokes, he is automatically a grade C. If the patient smokes less than 10 cigarettes a day, then he is a grade B. If the diabetes is uncontrolled and HbA1c is more than 7, then he is automatically a grade C. The last step is this patient stable or unstable? So as a periodontal practice, I do have a lot of patients who have had past bone loss, and we have maintained them now, and the tissues are healthy and they're doing an excellent job with home care. But if you just look at the radiographs for the first 4 steps, that what you're doing, that can mislead you to a wrong diagnosis. And stable and unstable differentiates between that. If there are active pockets or open pockets, whatever you want to phrase it, if there are pockets and bleeding and probing, signs of inflammation, then you need to treat them. So that's an unstable case. If the tissues look healthy and radiographs are just pointing you towards past bone loss or any periodontal surgery which was done, and you can see minimum or less than ideal support for teeth, then that's a stable case. Excuse me. Okay, so let's look at some examples. So I have case 1, who is Mr. B, 46-year-old. He's a smoker. And again, I don't specify how much he's smoking, and you'll soon find out why. So these are the full mouth radiographs. So according to my 6 steps, my first step is this a periodontal patient? So I look at the radiographs. Yes, I do see a lot of bone loss around the molars, some bone loss around the incisors, upper incisors, molars. Yes, this is a periodontal case. Okay, what's the stage? So I pick out the worst tooth. So just by looking at the radiographs, and I pick out number 26 as being my worst tooth in the mouth. Okay, I can safely say the bone loss is up to the apical third. That already puts the patient at stage 4. Remember, coronal third of the root is stage 1 or 2. Middle third is stage 3. Apical third is stage 4. So this is clearly a stage 4 patient. Generalized, localized, molar incisors, and I would say generalized. What is the grade of the patient? Okay, so my worst tooth is number 26. Bone loss is 90%, which is more than the age of the patient, who is 46. So it's a rapid rate of progression, so it's grade C. What are the risk factors? That's my next step. He's a smoker. That's the risk factor, the current smoker. Is it unstable or stable? For this step, you have to look at the periocharding, and that's I see a lot of probing depths more than 4 millimeters, some bleeding on probing here and there. So he's an unstable case. So that's my diagnosis statement, which I do recommend for every patient. You can follow this format, or you can follow some other format, but you should include a diagnosis or diagnostic statement in your chart notes to define all these things, that yes, he's a periodontitis case, he's a stage 4 generalized grade C with risk factors of smoking, and he's an unstable case, so he needs treatment. Some kind of diagnostic statement in your charts. Okay, let's look at case 2. This is Miss B. She's 61 years old. She is not a smoker, not diabetic or uncontrolled diabetic. Just has some fremitus with 6, 11, 12, and 13. So fremitus is a sign of occlusal trauma. So it's pointing us towards the complexity of the management of this case. Okay, so my first step is this periodontitis? Yes. Looking at the radiographs, I would say yes. There's some bone loss around number 6, 8, 9. Okay, so this is a periodontitis case. Is this what stage is it? Pick out the worst tooth on just by looking at your radiographs. I would say number 9 is my worst tooth. The bone loss looks to be about the middle third of the root, so it's a stage 3. Okay. Is it generalized, localized, molar incisor? I would say it's more localized at this point. Okay. What grade? So I would say assign a percentage of bone loss to your worst tooth. So I would say about 50-60% of bone loss. I would say it's similar to or less than the age of the patient, the percentage. So I would say it's a grade B. What are the risk factors? He's not a smoker. He's not diabetic. Okay, so that's my grade B. The risk factors, I'm sorry. No risk factors. Is he stable, unstable, for which I have to look at the charting. Yes, there are some active pockets and bleeding on probing, more than 4 millimeter pockets. And bleeding on probing, as defined by the new framework, you should have bleeding and probing more than 10% to consider it a gingivitis case, a plaque-induced gingivitis case, or a periodontal case, unstable case, I'm sorry. Okay, so that's my diagnostic statement. Yes, he's a periodontal patient, stage 3, localized, grade B, no risk factors, but is unstable. Okay. I did happen to have radiographs within the past 5 years for this patient, and as I said earlier while describing the grade and how you come to a grade for a patient, I said use direct evidence first. So this is a direct evidence. If I have radiographs from the past 5 years, I compare my worst tooth. Okay, so my worst tooth was number 9. The bone levels don't look that bad. Maybe the angle deceives it a little bit, but the radiograph on the right, it doesn't look like the bone loss is up to the middle third. So the progression within the 5 years has been rapid. So I would modify or upgrade this patient to a grade C. So this would be my new diagnostic statement. So I just put in this example to make it a little bit more clear, and what evidence of progression you should use. Direct evidence is always the best. Okay, now let's look at number 3, Mr. M, he's 70 years old. Um, Again, I'm going to walk through the first 4 steps of my 6-step process, and just by looking at my radiographs, I can assign a stage and grade. Okay, is this a periodontal patient? Yes, he is a periodontal patient. What's the stage? So I have to pick out the worst tooth, and I would say number 15 is the worst tooth. The bone loss is up to the apical third, so it's a stage 4. Okay, is it generalized, localized, molar incisor pattern? I would say more than 30% of the teeth are involved, so I would assign it a generalized case. Okay, what is my grade? The grade is percentage of bone loss divided by age. I have 90% of bone loss and he's only 70, so that means it's a grade C. Risk factors, I do not have any risk factors as I can remember. Yes, no risk factors. Stable, unstable. I look at my period charting and clearly is an unstable case. Okay, so that's my diagnostic statement. Hopefully these examples are making it a little bit easier for you guys to follow, and if there are any questions, please email me, call me, and I would be happy to answer those questions. Okay, my last case is Miss F, who is 65 years old and she's a smoker. Again, I would prefer full mouth FMX, but this was a pan sent by a referring dentist, so I try to use it as much as I can. Again, I want to point out the missing teeth. The patient has already lost all the maxillary molars. Again, the caveat is, according to the new framework, those teeth have to be lost because of periodontal disease. If they were lost because of caries or any other reason, you cannot count them towards assigning a stage to this patient. So you want to make sure those teeth were lost because of periodontal disease. Okay, so that just by counting teeth and looking at your handout, this patient is already a stage 4 patient. Now I walk through my steps. Yes, is this a periodontal patient? Yes, he's a periodontal patient. Is what stage? So I pick out a tooth, which is the worst. I would say, excuse me, I would say number 24 is the worst tooth, and I can probably see bone loss up to the apical third of the root. So again, that puts us again back to stage 4, which we already determined based on just counting missing teeth, and if we know for sure they were lost because of periodontal disease, so that makes it really easy. Generalized, localized, I would say generalized. Grade, the percentage of bone loss on my worst tooth is more than the age of the patient, so it's a grade C, which is rapid progression of the disease. Risk factors, she's a smoker, that's my risk factor. Stable, unstable, then I go to my chart and look for my probing depths. Bleeding on probing, yes, this is an unstable case, which means she needs treatment. If it's a stable case, of course, this would be treatment in the sense they would need just perio maintenance. Okay, so that's my diagnostic statement. That concludes our presentation, and I do want to share with you all that we do have a new machine. It's called X-Guide for placing implants precisely and accurately in the planned position. What this machine allows is step by step, drill by drill, live navigation. So you cannot, so whatever actually you planned in your CBCT, you can duplicate that exactly using this machine to place the implant. So problems of malpositioning an implant, incorrectly positioning an implant, or hitting a nerve or artery, or all those complications are minimum or next to minimum or next to non-existent with this technology. I'm happy to share that we have that technology available here in Roseburg, and we do have a CBCT machine available too. And if there are any patients that require implants or good candidates for implants, I would be happy to help them out. And most of the cases with this technology, we can do it the same day if things are lined up correctly. Um, Again, I want to thank everyone for watching this, and to claim your CE, please call us or email us. And Gretchen up front would ask you for a password, and that password is UMQA. Again, the password is UMQA to claim your CE. We do have a Facebook and Instagram page, and during the COVID-19 closure, me and Gretchen, we did create a funny video for the community and our fellow dentists to like and enjoy. So please watch that on Facebook. You can find us under UMQA Periodontics and Implants on both Facebook and Instagram. And I again want to thank everyone for watching this. Thank you.